Hi everyone, I'm Sir July, and for this slide sets, we will be discussing schistosomiasis. Schistosomiasis is a chronic and parasitic disease caused by blood flukes. It is also known as bilharzia or bilharziasis or snail fever. It is also classified as a vector-borne disease. Highlighted in this throwback slide, we note that schistosomiasis is caused by a helminth and the vector is an aquatic snail. Helminths are worm-like parasites that survive by feeding on a living host to gain nourishment and protection, sometimes resulting in illness of the host. There are a variety of different helminths, from the very large to the microscopic. Helminth is a general term meaning worm. For schistosomiasis, it is caused by tremathodes or flukes of the genus Schistosoma. There are five species: S. hematobium, S. mansoni, S. mekongi, S. intercalatum, and S. japonicum. S. japonicum is endemic in the Philippines. Famorca specifies the provinces of Leyte, Samar, Sorsogon, Mindoro, and Bohol. According to the WHO, schistosomiasis is endemic in 28 provinces in 12 regions in the Philippines. As a nice to know, there is actually a schistosomiasis hospital that I learned while making this presentation. Some of the information that I have presented here will be from their IEC materials. The intermediate host is the snail Oncomelania quadrasi, and this is one of the most frequently asked questions regarding schistosomiasis. The definitive host is man. The definitive host is the one which harbors the adult parasite and where the parasite reproduces sexually. The intermediate host is the host which harbors the larval stage or the asexual form of the parasite. In case of schistosomiasis, the Schistosoma japonicum larva, termed as cercaria, is swimming in infested waters and enters the body by penetrating the skin. The larva comes out from the snail, which is the Oncomelania quadrasi or the intermediate host, which is as small as the grain of rice. This illustration shows the life cycle of Schistosoma. Schistosomes reproduce asexually in freshwater snails, which are the intermediary hosts. A larval form, the Sarcaria, is released from the snail and can burrow into the skin of the definitive host, man. In humans, schistosomes migrate to the bloodstream where they mature into adult worms. Eggs produced by the female worm are released in the environment. The eggs hatch into a second larval form, the Miracidia, which can infect the snail. Vulnerable population include children and adolescents of both sexes, but farmers are more affected, followed by fishermen and unskilled laborers. There is low incidence among professionals. Symptoms of schistosomiasis are not caused by the worms themselves, but by the body's reaction to the eggs. Many infections are asymptomatic. Acutely, it may present as swimmer's itch or katayama fever. Swimmer's itch is also known as cercarial dermatitis. It is a local cutaneous hypersensitivity reaction following skin penetration by cercaria. It appears as small, itchy maculopapular lesions as seen in this slide. Katayama fever or acute schistosomiasis syndrome is a systemic hypersensitivity reaction that may occur weeks after initial infection, especially by S. mansoni and S. japonicum. Since S. japonicum is endemic in the Philippines, we will be focusing with the S. japonicum infection. This IEC material from the Schistosomiasis Hospital illustrates the symptoms of S. japonicum infection. S. japonicum infection will cause gastrointestinal symptoms such as stomach pains, loose bowel movement, and bloody mucoid stools. Continuing infection may cause granulomatous reactions and fibrosis in the affected organs such as the liver and spleen, and with associated signs and symptoms. These symptoms include severe jaundice, edema, ascites, hepatosplenomegaly, and signs and symptoms of portal hypertension. In the Schistosoma genus, it is the species S. hematobium that causes a primary genitourinary symptom. It presents with blood in the urine or problems with passing the urine. Of clinical importance is that S. hematobium can also lead to increased risk of bladder cancer. I remember it as hematobium sounds like hematuria, which is blood in the urine, and that makes me correlate that S. hematobium affects the genitourinary tract. The diagnosis of schistosomiasis requires detection of infection. Direct assays include demonstration of eggs in the stool or urine via microscopy, or demonstration of schistosome antigen or DNA in the blood, urine, and/or stool. Indirect assays include demonstration of antibody in blood via serology. Eggs of S. mansoni, S. japonicum, S. hematobium, S. mekongi, and S. intercalatum can be found in stool, although S. hematobium is found principally in the urine. In the endemic setting, the Catocad's method is a common thick smear technique using 5 milligrams of stool examined with a low-power microscope lens. It is relatively easy to perform but lacks sensitivity in light infections. Techniques to detect parasite antigens are already used qualitatively and are commercially available in a point-of-care format. These tests are particularly useful for schistosome eradication programs in low endemic settings and in travelers with low parasite burden. Serologic tests are a useful diagnostic tool in the absence of egg detection via microscopy, particularly for travelers who generally have a low parasite burden. In general, serologic tests are negative during the acute infection and turn positive 6 to 12 weeks or more after exposure. Antibodies are usually detectable before eggs are detectable. Biopsy is useful as a diagnostic tool in the setting of ectopic disease manifestations and in the absence of demonstrative laboratory diagnostic tools. In the setting of intestinal schistosomiasis, biopsy of rectal or higher intestinal tract mucosa, even in the absence of polyps, may demonstrate characteristic granulomas surrounding egg embedded in the mucosa. In the setting of genitourinary schistosomiasis, cystoscopy with bladder biopsy is not needed in most cases, but can be performed if the diagnosis is suspected and eggs are not found in the urine. Safe and effective medication is available for treatment of both urinary and intestinal schistosomiasis. Praziquantel is a prescription medication taken for 1 to 2 days to treat infections caused by all schistosoma species. It causes calcium influx and spastic paralysis of adult worm. As previously mentioned, it is taken for 1 to 2 days. For prevention, environmental sanitation measures include using water-sealed toilets, use of water from pitcher pumps or artisan wells, and use of footbridge over snail areas and control of stray animals. Snail control measures include draining fields through canals, construction of fish ponds in streams and small swamps that are difficult to drain, filling up snail areas with earth or other suitable filling materials, spraying snail poisons or molluscicides, and proper cultivation that disturbs snail habitat and thus exposes snails to sun. The CDC adds that one must avoid swimming or wading in fresh water when you are in countries in which schistosomiasis occurs. Swimming in the ocean or in chlorinated swimming pools is safe. One must also drink safe water. Although schistosomiasis is not transmitted by swallowing contaminated water, if your mouth or lips come in contact with water containing the parasite, you could become infected. Water used for bathing should be brought to a rolling boil for 1 minute to kill any cercariae. When there is an accidental brief exposure to water, vigorous towel drying after the accident may prevent parasites from penetrating the skin. Applying 70% rubbing alcohol to the skin to kill all surface larvae may also help. However, do not rely on vigorous towel drying alone to prevent schistosomiasis. That ends the presentation for schistosomiasis. Pause this video, gather your thoughts, and when you are ready, let us have a practice test. Question number 1. Which schistosomia species is endemic in the Philippines? A. S. hematobium, B. S. mekongi, C. S. japonicum, D. S. mansoni. You have 5 seconds. And the correct answer is C. S. japonicum. What is the definitive host in schistosomiasis? A. Schistosoma japonicum, B. Oncomelania quadrasi, C. Human, D. Cercaria. You have 5 seconds. If you answered C, you are correct. Which schistosoma species can cause bladder cancer? A. S. hematobium, B. S. mekongii, C. S. japonicum, D. S. mansoni. You have 5 seconds. A. S. hematobium is the correct response. What is the drug of choice in schistosomiasis? A. DEC, B. Ivermectin, C. Albendazole, D. Praziquantel. You have 5 seconds. And the correct answer is D. Praziquantel. If you got 4 questions correctly, you did a good job. If not, rewind this video to check your answers. This ends the slide set. Please do not forget to subscribe to my YouTube channel, Memory Aid Nursing. Thank you.